In the interest of time and keeping things on schedule, we're going to get started with our first lecture, given to us by somebody who takes care of TTP patients on a daily basis and has made efforts to get here. Works out of the Ohio State University with Spiro Cadlin as well, so you'll probably see his picture at the end here. Leanne has a great connection to the patient base and has been here for 3 years now. So really appreciate her. She's going to be speaking about if there is no plasma exchange in the future, which I'm sure isn't a topic anybody's interested in, but I think is one of the best ones that we're going to discuss this weekend. With that, I'll hand that over.
All right, so thank you all for coming today. As Claire mentioned, today's focus is talking about how will we be utilizing plasma exchange in the future of immune-mediated TTP. To overview today's presentation, we're going to talk about the pathophysiology of TTP, its history, what are the current therapies or modalities, and then what are emerging treatment approaches. So let's overview the mechanism of TTP. This graphic shows normal ADAMTS13 activity on the top and ADAMTS13 deficiency on the bottom, which is what occurs in TTP. Normally, shear stress activates or unfolds von Willebrand factor, and ADAMTS13 cleaves the VWF. And this allows for platelet binding to help form a plug when there's bleeding. In TTP, ADAMTS13 cannot cleave VWF. As you can see, those X's there are antibodies that either clear or neutralize it. And this leads to ultra-large VWF multimers that excessively bind platelets, leading to microvascular thrombosis. So you might remember this slide last year from Dr. Scully's talk on TTP, but I think it does a really nice job showing normal blood clotting in a different way. So it's helpful to think of the ADAMTS13 as scissors that cut or cleave VWF and makes these smaller strands here. So the VWF are the strands up there, and the scissors are the ADAMTS13. So again, when VWF is cleaved, it's going to properly bind platelets and form a plug, if you will, or a clot. So if you're in the kitchen, you touch your finger when you're chopping a vegetable, okay? What you want to happen. Then over there on the left, you can see the von Willebrand factor ladder. As VWF strands or multimers get smaller, they move further down the ladder. So they migrate further across, and they're there at the bottom. And this slide shows what happens with TTP. So antibodies either clear or inhibit ADAMTS13. You can see there marked by those green triangles. And the ADAMTS13 cannot adequately cut the von Willebrand factor. And this leads to ultra-large multimers and causes excessive platelet aggregation. And this is ultimately what leads to the low platelet count or thrombocytopenia when someone presents. Platelets aren't getting destroyed, but they're rather getting used up to make these small blood clots. These small blood clots then go into the microvascular system, and red cells, which are the red circles there, cannot adequately pass through these vessels. They get sheared, which leads to the schistocytes that are seen on slides or blood smears. And this is what leads to anemia when the patient presents what we call microangiopathic hemolytic anemia. So although today's focus is on immune-mediated TTP or acquired TTP, as the name would indicate, it's autoimmune. Treatment involves plasma exchange or PET, steroids, taflucizumab, and rituximab. So I think it's important to mention congenital as well. This involves an inherited mutation of the ADAMTS13 gene. And treatment for that involves, or traditionally has involved plasma infusion, and more currently recombinant ADAMTS13 or Adima, which is the brand name. This is an ultra-rare form of TTP, and it represents less than 5% of all cases. This little picture here is more representative of the peak of episodes in congenital TTP. You'll see pregnancy there as well, which is also a trigger for acquired or immune. And The reason I want to mention that is although low Adams 13 is a risk factor for having an episode or an acute episode, it's not necessarily going to automatically mean someone has an episode. So TTP requires what's called a second hit or a trigger, and pregnancy is that for both congenital and immune. So Dr. Eli Moskowitz published the first known case of TTP, and it was dubbed Moskowitz syndrome. In his publication, he describes a 16-year-old girl who had graduated elementary school and completed business school. She had spent the weekend at the beach with her family, and the following day she awoke with weakness in her arms and pallor. Her symptoms progressed over the following days to include fever, and she was admitted to the hospital 9 days after her initial symptoms. Physical exam showed petechia, and there was no platelet count measured at the time. She progressed to signs of kidney damage and developed partial paresis of her left side. She eventually fell into a coma and passed 5 days after presenting to the hospital. So this image was included in his original paper, and Moskowitz describes the thrombi present throughout the microvasculature in the heart muscle. And this is what ultimately led to the death of the young girl. TTP, when it's not treated, ultimately leads to a cardiac. So this really overviews the history of TTP from Moskowitz's original case to where we are now. So in 1947, the disease actually gets the name TTP. And this occurs when other researchers publish other cases and they look into them and they really see that it's a distinct entity between the more common iTTP, which I'm sure you all have heard of as well, or maybe even were misdiagnosed with it initially. So then in 1966, investigators published the pentat of TTP and described its symptoms. And this becomes universally recognized by medical professionals. In 1978, Dr. Upshaw published a case report of a 29-year-old woman who was suffering from recurrent episodes starting at 6 months old. She had been treated with corticosteroids and splenectomy without success of getting remission. However, he noticed that she would improve with transfusions of whole blood rather than packed red cells. And he had hypothesized that what she was actually benefiting from was the plasma portion of the whole blood. In the 1980s, ultra-large VWF multimers were first described in patients with relapsing TTP. And then in 1996, a new metalloprotease was isolated from plasma that specifically cleaved von factor. In 1991, the first controlled study of plasma therapy for acute TTP was published. And investigators compared plasma exchange to plasma infusions in a randomized controlled trial and found that patients who were treated with plasma exchange had lower mortality rates. And this really brought plasma exchange into frontline or first-line therapy for iTTP. Then in 2001, the protease that was isolated in 1996 was successfully purified and sequenced, identifying Adams TF13. In 2002, there's a case series published showing that rituximab is beneficial for patients with refractory TTP. And then in 2017, the recombinant Adams13 trials began in humans for congenital TTP. In 2019, the FDA approved Cablevy for immune TTP. And then in 2023, the FDA approved Adzynma for congenital TTP. Really, there's been an evolution in recognizing and treating TTP from Dr. Moskowitz's initial case in which he described this pentat of symptoms. So we can really see that now as we have gone to recognize that we don't need to wait for this pentat, that the death rate of TTP has really decreased throughout the last century. We really just see the thrombocytopenia and the microangiopathic hemolytic anemia, and that should be enough for the doctor to suspect TTP. So this diagram nicely depicts the milestones in TTP and how these advances have affected mortality and the goals of TTP and its understanding as treatment advances. Today we're looking at, can we treat TTP without plasma exchange, and how can we optimize and provide more uniform care and improve long-term outcomes for patients? So treatment for TTP has two phases. acute and chronic or preventive. In the acute phase, we want to stop end organ damage, and this is marked by a normalized platelet count and improving LDH. Treatment includes plasma exchange, immunosuppression with high-dose steroids and rituximab, and caplacizumab. And then recombinant Adams-13, again, is available for exacerbations for patients with congenital TTP, as well as it's used as prophylaxis for these patients. And then in the preventive or prophylactic phase, we're really monitoring patients about every 3 months to see where their Adams-13 activity is. And we treat with preemptive rituximab if we start to see that their activity is declining. 20% is that hard cutoff, but it honestly really depends on what insurance will approve. So typically less than 30% would be a good case. So again, the goals of acute treatment in TTP are to stop the end organ damage and allow for recovery. And plasma exchange is the initial treatment for this. We monitor for normalization of platelet count and improving LDH as surrogate markers for ongoing microvascular injury. And this usually takes 5 to 7 days, so it takes a bit of time. We also want to prevent exacerbations in this acute phase of treatment. And this is defined as having to restart plasma exchange less than 30 days after initially stopping plasma exchange for this episode. And this occurs in about 30 to 40% of patients, or at least when we weren't using capital systems. So some of you may be familiar with an apheresis machine, and plasma exchange works by removing anti-Adams-13 antibodies and ultra-large BWF and adds back in donor Adams-13. But plasma exchange isn't without risk. Patients require a large catheter, and this has risk of infection and bleeding. There's also adverse reactions to plasma exchange itself, and it's time intensive for patients. So immunosuppression is another mainstay of treatment. Again, corticosteroids and rituximab are great at suppressing antibody production of against Adams-13. However, they don't clear that. And though these immunosuppressants are effective, they take time and cannot prevent an early exacerbation or resumption of plasma exchange. So what this first graph shows are some early studies comparing cyclosporine to prednisone. Cyclosporine we don't typically use up front anymore. So what this is showing is that the patients have been stabilized after leaving the hospital, and it takes about 14 days before we can see recovery of the Adams-13 activity to over 20% in the prednisone. So this second graph is from a UK study that shows that the median time to respond to rituximab, which is uniformly given in the UK on day 3 from presentation, is about 22 days after admission. And the vast majority of exacerbations in iTTP occur in the first 14 days. So again, this just doesn't work fast enough to prevent an exacerbation. So rituximab briefly works by suppressing the lymphocytes or clearing the lymphocytes that produce the anti-Adams-13 antibody. So some issues with it are intolerance or severe reactions. And then over time, we can see that patients' duration of remission in their Adams-13, that starts to wane. So obinutuzumab is an alternative, and there's going to be another talk on that later today by Dr. Metson. So I encourage everyone to go here. So we mentioned these exacerbations, and again, these are defined as recurrent thrombocytopenia less than 30 days after the last plasma exchange or anti-von Willebrand factor therapy. Taclizumab is an antibody that works by blocking platelet binding to the A1 domain of von Willebrand factor, preventing platelet aggregation and clots in the microvasculature, as shown here if you remember in the earlier slide. So this is great for preventing exacerbations because it stops the clots from forming in the small vessels, and this prevents and stops further end organ damage. However, it's not for all patients who come in and they're experiencing major bleeding. All right, so you guys are probably wondering why there's a picture of llamas here. So caplacizumab was actually initially isolated as a nanobody from llamas, and if you go there, there's still a small farm right here in Belgium that the drug company has used on us. So, just a little fun fact there. So Titan was a phase 2 study in which patients with iTTP were randomly assigned to tafasitamab or placebo or receiving plasma exchange and immunosuppressive therapy for 30 days after their remission. And the primary endpoint was the time to response, which was defined as normalization of their platelet. In the Titan study, the median time to achieve a normal platelet count bond, as you can see in that top red bar there, was 3 days for the tafasitamab arm and almost 5 days for the placebo arm. 3 patients in the tafasitamab group had an exacerbation compared with 11 in the placebo, and 8 patients in the tafasitamab group had a relapse in the first month after stopping the study drug. And of that group, 7 had ADAM13 activity that remained less than 10%, and this suggests that they had unresolved autoimmune activity. Exacerbation occurred anytime between days 1 and 30 after the last plasma exchange, so it's possible that the capital was just stopped too early. Importantly, the relapse rate shown here was before there was the formalized definition of exacerbation that we now know is within the first 30 days of the last plasma exchange and before recovery of the ADAM-TS13 activity. Patients were analyzed even if they had ADAM-13 activity less than 10%. So, like I said, we see this in practice with tablets stop too early. Patients are going to have exacerbation. So this graph shows the 4 different groups of patients: no exacerbation, relapse of the presenting episode, and then a new episode. And this compares Pafla to placebo arm, and this again just emphasizes you can see that dashed line at the bottom. Most of these occurred in patients who still had ongoing autoimmune activity and low ADAM. So Hercules was a phase 3 study in which patients with iTTP who had received one plasma exchange were randomized 1-to-1 to placebo or tafasitamab in addition to daily plasma exchange and corticosteroids. Tafasitamab was given daily during plasma exchange and for 30 days total. If after 30 days, you can see by that vertical line there was evidence of ongoing disease, including low ADAM13 activity, investigators could extend treatment for another 4 weeks, and patients were followed for 28 days after the last dose of study drug. The primary endpoint was time to normalize platelet count within 5 days of stopping plasma exchange. Results demonstrated that patients treated with caplacizumab were over 50% more likely to achieve a platelet response or normalization at any given time point. And those who had been treated with Capla had a 67% reduction in their recurrence. And importantly, relapse follow-up occurred in the setting of Adam's activity still less than 10%, which demonstrates that Capla helps prevent the microvascular clots. It doesn't really correct the underlying pathology of TTP by stopping antibody production. So this is the first case report of caplacizumab without plasma exchange that was published in July of 2019. The patient was a previously healthy 63-year-old woman who was a Jehovah's Witness and had presented to the emergency room with spontaneous purpura and no other symptoms. Her hemoglobin was normal, but her platelet count was low at 14,000. The presumptive diagnosis was ITP, and she was initially only treated with steroids. However, on day 2, labs demonstrated evidence of microangiopathic hemolytic anemia, and this is concerning for TTP. On day 4, her ADAM13 activity returned less than 5%, which confirmed the diagnosis of TTP. As a Jehovah's Witness, she declined plasma exchange but agreed to steroids and rituximab. Her symptoms progressed, and she developed severe neurological symptoms, and compassionate use of caplacizumab was requested by her treating team. She received her first dose on day 11, and after that, her neurologic symptoms resolved. And 3 days later, her platelet count normalized. By day 20, she was discharged from the hospital. She completed rituximab and continued caplacizumab through day 40 and eventually normalized her ADAM13 activity on day 48. And this is another case report of caplacizumab without plasma exchange. And this was published after that initial case. This patient was a 56-year-old woman with a history of relapsing TTP who presented to the clinic for her routine Adams 13 monitoring. She reported symptoms of fatigue, abdominal pain, and nausea for the previous 4 days. Her platelet count returned low at 86,000. She had a mildly elevated LDH and schistocytes on her blood smear. So the presumptive diagnosis was relapse TTP. She strongly desired to avoid hospitalization, plasma exchange, and high-dose steroids based on her past experience treating her TTP. She had a strong support system at home who can ensure she was safe, and the next morning, her Adams 13 activity returned undetectable, confirming diagnosis. After extensive discussion with the patient about the data available in caplacizumab and the case report of the Jehovah's Witness, she agreed to start caplacizumab and rituximab for immunosuppression. That day, she received her first dose of intravenous caplacizumab, and then she came the following 2 days for her subcutaneous injections and teaching on injections. Her platelet count recovered 48 hours later. You can see that there on the blue line. And her Adams 13 activity recovered to 31% on day 44, and caplacizumab was then discontinued. And then her Adams 13 activity actually normalized 2 months after this relapse, and it was up to 84%. So this brings me to the Mayari study. So this is a phase 3 trial evaluating the efficacy and safety of caplacizumab and immunosuppressive therapy without first-line plasma exchange for adults with iTTP. Patients received daily caplacizumab plus immunosuppressive therapy. They were included if they had a clinical diagnosis of TTP defined by a platelet count or a low platelet count and evidence of microangiopathic hemolytic anemia. And they had to have their Adams 13 activity confirmed within 48 hours of presentation. Patients were excluded if they had severe neurologic or cardiac damage. So again, no plasma exchange was necessary, but investigators could administer it if there was signs of clinical deterioration in the patient and they weren't improving. The primary endpoint was the proportion of patients achieving remission without plasma exchange. So the results are pretty impressive. They show that over 90% of patients achieved remission without plasma exchange. And more than 95% achieved remission when they included the patients who had plasma exchange. You can see there in the circle there, these 3 patients failed caplacizumab therapy, meaning 2 of them required plasma exchange. 1 improved, the other one dropped out before the end of treatment. And then this third patient here was considered refractory because they did not normalize their platelet count. However, it's important to note that they actually had thrombocytopenia dating back to the 1990s, so they were able to get back to their baseline platelet count, albeit not being normal platelet count. So I'm assuming they probably had chronic ITP. One of the secondary endpoints was the median time to platelet response, which was 4 days in the caplacizumab arm. More than 75% of patients achieved a platelet count response within 5 days after the initial caplacizumab dose. Also, over 97% of patients achieved a clinical response during the study period, and this was defined as a platelet count that had normalized in an LDH that was improving less than 1.5%, the upper normal limit, with no evidence of new or progressive end-organ damage for at least 2 consecutive visits. This doesn't include the unevaluable patient who was just mentioned with long-standing thrombocytopenia, despite their platelet count returning to baseline. So importantly, there were no exacerbations, relapses, or TTP-related deaths. To summarize, caplacizumab is an effective treatment when combined with immunosuppressive therapy, even without first-line plasma exchange. It's safe for patients not experiencing major bleeding at the time of presentation. So is there another therapy that could be an option for patients who might not be suitable to start caplacizumab? Yes, it's recombinant Adams 13 or Edzymon. So both iTTP and congenital TTP, right, are defined as an Adams 13 deficiency. And the benefits of the plasma is that it supplies donor-derived Adams-13. Currently, recombinant is only FDA approved for congenital TTP, but it is under investigation for iTTP. So Dr. Scully presented this abstract at EHA, or the European Hematology Association, in 2023 regarding a phase 2 study in which recombinant Adams-13, together with plasma exchange, demonstrated that high doses of recombinant Adams-13, which is dosed twice daily, were able to achieve normal Adams-13 levels after 3 days of treatment. There's currently a prospective phase 2 study with recombinant Adams-13 called TAC 755 for iTTP without plasma exchange. So this is ongoing. This is the study design here. There were 23 patients who completed the study and all received plasma exchange and immunosuppressive therapy. There were 3 arms. The first is placebo, and then the second is once daily recombinant Adams-13, and then the third was twice daily recombinant Adams-13. Drug or placebo was administered immediately post-plasma exchange and again 12 hours later. Patients received treatment until clinical remission was achieved, demonstrated by a normal platelet count and improvement in LDH for at least 48 hours following initial platelet normalization. So what this graph does is it demonstrates the median Adams-13 activity was consistently higher in arms 2 and 3. And again, those are the treatment arms that received study drug. So you can see the once daily arm looks probably light blue to you guys. So it looks like to me. The graphics are a little different here on the computer. And then the twice daily arm was that darker line there. And then those vertical bars are the times of plasma exchange. So Adams-13 activity was measured right before and again following plasma exchange. And so we can see that really patients are getting improvement in their Adams-13 activity pretty rapidly. It's measured throughout the study at multiple time points in both of the arms that received recombinant. So again, the recombinant is replacing Adams-13 activity, but there's also the thought that it could be binding to the anti-Adams-13 antibodies and chelating those. We don't know this for sure. So are we overwhelming the antibody and replacing Adams-13? So will plasma exchange stay around? Some experts say yes. They still think there's a benefit of removing the antibodies in ultra-large BWF multimers and adding back the Adams-13. And then could you potentially use both recombinant for Adams-13 and caplacizumab at the same time to treat a patient? We don't know yet. There's future studies hopefully forthcoming on that. I want to give a big thank you to USTMA and Claire for hosting and organizing this event annually. And there's my attending physician, Dr. Catalan. He's been a great mentor and teacher and very supportive and encouraging. And thank you to all you guys for being here and just being so invested in the investigation of TTP and advancing treatment. I'm sorry, I'm having a mm-hmm. You're saying buying time for plasma exchange? Mm-hmm. So it's cost related, unfortunately. So Cabenuva's, yeah, pretty expensive per dose. I'm pretty sure at our institution, I'm pretty certain at our institution, Dr. Catalan is actually the only physician allowed to write for Cav-Levy because they have such a restriction on who can write for it because of how expensive it is. Mhm. Mhm. Again, it stops those clots, yeah. Mhm. Yeah, yeah, and that's my impression from talking to other centers and talking to Dr. Catalan, yes, that cost is the big barrier for, stocking it. Do any Yeah, Dr. Beltrami, thank you for weighing in.
We should be, thank you. If people are thinking TTP, we should be advocating for starting treatment as soon as possible, whatever that treatment is. And I think that's part of what the work that the USTMA does educating other physicians and hematologists and things like that. So 100%. It comes down to early recognition. And in the minute that you think TTP, that's when we get the ball rolling. Yeah, I think that's what we're all hoping.
It has to be your the team at that hospital has to be comfortable also shifting away from some older treatment paradigms too, and what are they comfortable with? What do they know, right? Not every institution is fortunate to have a TMA expert there. Even at our hospital, we're fortunate to have Dr. Catalan and Dr. Beltrami there, who the other hematologists who aren't expert in it can reach out and say, hey, would you give plasma exchange, or what do you feel comfortable doing with this patient? Do you think they need high dose? I mean, we like again, we're very fortunate, but yeah, he gets phone calls for sure from outside hematologists. Mhm. I think adding it in as the standard of care, presenting to your hospital the importance of it. It's FDA approval. What our international working group treatment guidelines have come up with. all these things. Unfortunately, I think it's going to be a cost issue as far as getting hospitals to have it readily available. And it takes patient advocates and physicians advocating. Yeah, so Mayari, right? And it's presenting things like Mayari that shows that there's no exacerbations, there's no treatment related deaths. And I think presenting that to the hospital too, that essentially having this available can prevent issues for patients. And if they're not providing, a standard of care that is available, or they don't have it readily available, that might be a problem later down the line for them if they didn't have that treatment available that's FDA approved for patients. Are there any other questions? So you're asking what are the differences between the congenital and the immune mediated? Yeah. So yeah. So it's going through. If you're thinking congenital, it's looking. Do they have antibodies or antigen present? Potentially genetic testing with genetics counselor too. It's looking at what is their baseline Adams activity. So it's a lot of things that they're looking at to differentiate between the two. Yeah. So you're asking, is the same drug company work? It's two different drug companies that produce Cablevy and recombinant. Yeah. Um, so what you're asking is there a lobbying group advocating for insurance companies to allow for Cablevy to be accessible before the Adams 13 is confirmed as being low? Is that what you're asking? Yeah. Okay. Um, Claire, do we have an advocating group for insurance companies to do that? I think it's really hard because every insurance company has their own policies, but we would not wait to say that someone's TTP while waiting for the Adams 13 to come back. That's really confirming a clinical diagnosis. So you're really waiting too long, in our opinion, if you're waiting for the Adams 13 to come back. But as far as the lobbying group, I'll let Claire weigh in on that.
So there's a number of ways that we're approaching this. Now, first of all, I don't know if you're aware, Canada doesn't offer Caplevy to TTP patients at all. They cannot get their health organizations to do that. So one of the things we've been working with is there used to be an organization there called Answering TTP. We've been working with the volunteers who used to work there to be able to support data to show that Caplevy is absolutely necessary for patients and it isn't just a cost barrier. There was recently a study published called the CAPLA 1000, which was an international effort from a number of investigators. It wasn't sponsored by a pharmaceutical company that demonstrated clearly, and the reason it's called CAPLA 1000 is because they looked over 1,000 patients. It's demonstrated clearly that there is a mortality benefit. So there is a reduction in death if you are able to use caplacizumab. And so what we've utilized is this peer-reviewed, evidence-based paper to support the fact that this is a standard of care. It's not just a maybe, it's not still in research. There is clear evidence that this is something that needs to be available to patients. So we have a template that we're able to provide to be able to do the prior authorizations and the appeals. We work closely with Sanofi to utilize any of the resources that they have to gain access. They used to be able to basically show up with a suitcase of caplacizumab